Welcome to the Cytokine Signaling Forum's highlights from ACR 2021, where authors will take us through their posters and presentations on cytokine signaling and JAK inhibitors. My name is Len Calabrese. I'm the head of the Cleveland Clinic's section of clinical immunology. You know, this year's ACR Convergence had a number of interesting presentations beyond the scope of rheumatoid arthritis. In this edition, we're going to listen to data on the use of upadacitinib in spondyloarthritis.
Hi, my name is Daniel Magliulo. I'm a second-year rheumatology fellow at Beth Israel Deaconess Medical Center in Boston, Massachusetts. On behalf of my co-authors, Dr. Stephanie Wade and Dr. Vasilios Kateris, I'm very excited to share the data from our abstract at the 2021 ACR meeting. Our abstract is entitled Optimizing SARS-CoV-2 Vaccine Timing in Rituximab-Treated Patients with Autoimmune Rheumatic Diseases, a Quality Improvement Intervention. We decided to study this topic shortly after the emergency FDA approval of SARS-CoV-2 vaccines in the United States. We know from past data from our patients that with autoimmune rheumatic disease on rituximab, that there is a clear impairment of humoral response to vaccines. There was also emerging data at the time that rituximab was a risk factor for severe SARS-CoV-2 infections, which made optimization of vaccine immunogenicity of the utmost importance. So onto our hypothesis and our aim. So our primary aim of this study was first of quality improvement within the rheumatology department at Beth Israel Deaconess Medical Center. We hope to improve vaccination rates and timing through both patient and provider education. Secondarily, when the data was available, we went back and chart reviewed and evaluated immunogenicity to vaccines and assessed the effect of various immunologic parameters on likelihood of vaccine response. So onto the methods, our inclusion criteria included any patient actively receiving rituximab for an autoimmune related rheumatic disease within the Beth Israel Deaconess Medical Center Rheumatology Department. Patients were excluded if rituximab was postponed or discontinued at the time of study start. Physician education was provided via a 1-hour virtual presentation. Education highlighted the data supporting the 2019 EULAR vaccine guidelines for patients on rituximab, and also the recent ACR COVID-19 task force guidelines. Timing of vaccination was recommended in accordance to the 2019 EULAR and ACR COVID-19 task force guidelines, which were to vaccinate patients at least 6 months following the last dose of rituximab and 4 weeks prior to the next infusion. Patient education was provided in the form of a standardized letter from the department on importance of vaccine and timing. Following the education, providers were asked to record their preference to time all patients' vaccinations according to these guidelines universally, or whether they were going to individualize vaccination plans based on patient risk factors. Vaccine timing was then measured through chart review and through telephone surveys of patients. And finally, when the data was available, vaccine immunogenicity was measured by the presence or absence of SARS-CoV-2 anti-spike antibodies at least 2 weeks following vaccination. This was analyzed in response to vaccine timing, and various other immunologic parameters were gathered to determine the effect on likelihood of response. In summarizing our results, regarding the rate and timing of vaccination, our cohort had a 95.2% vaccination rate, which is far higher than both the state and national rates for SARS-CoV-2 vaccines. And vaccination rates were also remarkably higher than historical rates of other recommended vaccines amongst patients on rituximab therapy, suggesting that directed patient education improves these rates. The median time from last rituximab infusion to first vaccine dose was 20.5 weeks, and to the second vaccine dose was 24.3 weeks when a second vaccine was given. The median time from second vaccine to rituximab infusion was 7.2 weeks. Patients whose providers expressed universal intent to time vaccines were more likely to be vaccinated at least 20 weeks post-rituximab than those whose providers took a more individualized approach, and this was statistically significant with a p-value of 0.04. Interestingly, the higher cumulative rituximab dose per patient at the time of study start was associated with vaccination under 20 weeks from last infusion. We can speculate that this may be related to provider concerns for more severe SARS-CoV-2 infections in these patients. However, this data was not available. Regarding immunogenicity of vaccines, 14 out of 42 patients, that's 39.4%, had positive anti-spike antibody titers. This percentage is similar to other cohorts that have come out in a similar time frame regarding these vaccines with patients on rituximab. There was a non-statistically significant trend towards older age in the seronegative group with a p-value of 0.06. A history of hypogammaglobulinemia, both IgG and IgM, was predictive of a negative anti-spike antibody titer post-vaccination with a p-value of 0.008. This remains significant even when correcting for medications and age. As you can see from figure 1, we performed a multivariate logistic regression analysis looking at age, corticosteroids, conventional DMARDs, and hypogammaglobulinemia remained statistically significant. There was no significant difference in anti-spike antibody titer positivity with autoimmune rheumatic disease diagnosis, whether that be rheumatoid arthritis, vasculitis, connective tissue diseases, IgG4 related disease. CD19 and CD20 counts were also not statistically significant between the two groups. Neither was steroid dose or concomitant DMARD use. And lastly, vaccine timing, surprisingly, was not different between seropositive and seronegative groups. Other studies have shown that B cell depletion is a strongly predictive factor for lack of humoral response to SARS-CoV-2 vaccines. And we hypothesize that our data did not show this, as patients who had B cells checked in our study had reconstitution at the time of vaccination, and therefore that difference was likely not reflected in our results. It was interesting that timing did not affect likelihood of seropositivity, as it has been demonstrated in other similar cohorts. However, there was only a handful of patients who were vaccinated more than 10 months after their last rituximab infusion, which appears to be the threshold where a significant difference was seen in other studies. So it is likely that our data did not reflect that. Regarding safety data, this was similar to nationally reported data by the CDC. The most common reported side effects were injection site pain and fatigue. There was no reported flares of rheumatic disease amongst our cohort and no serious or life-threatening side effects requiring hospitalization. So overall, the strengths of our study is the relatively robust size of our cohort. We had 72 patients in our cohort, and we had 42 patients who had SARS-CoV antibodies checked, which is relatively large. And the other major strength of our study is it represents a pragmatic effort from a single center to improve vaccination rates and timing for a high-risk population in the midst of a SARS-CoV-2 pandemic, and highlights the difficulties that were likely faced by institutions and clinics worldwide in this unprecedented situation we were in. The limitations of our study, one, we did not have a control group of which to compare the quality improvement intervention on vaccine rates and timing. We instead were only able to compare to public health data and to historical data from other vaccines. Regarding other limitations, the observational nature of our study prevented our ability to control what laboratory or clinical data was collected from patients. This led to several sample size limitations and may have underestimated the predictive value of several parameters. In particular, our data may represent the actual degree to which B cell depletion affects seropositivity rates. And furthermore, we were unable to assess the role of any T cell responses to SARS-CoV-2 vaccines, which is an area of heavy interest and study right now. And due to the limited time of follow-up after vaccination, we were also unable to comment on post-vaccine SARS-CoV-2 infection rates and severity, which is perhaps the most important patient-centered outcome. However, this is certainly a highly important area for further study, as is the effect of the third vaccine on seropositive rates in this population. So in conclusion, patient and physician education may improve rates of patient vaccination and adherence to societal guidelines for vaccine timing. The low seropositivity rate in our studies suggests that recommended interval from last rituximab of 6 months may need to be extended further. And finally, regular monitoring of immunoglobulin levels may be important in predicting immunogenicity to SARS-CoV-2 vaccination, and may be a lab parameter that should be monitored by clinicians moving forward. So thank you very much for taking the time to listen to our study, and we're excited to hopefully publish this data in the near future.
Hello all. Thank you for this opportunity to share our work on rituximab impairs B cell response, but not T cell response to COVID-19 vaccine in autoimmune diseases. This work has been involving a lot of people in our department, at the rheumatology department in Bicêtre Hospital in France. We're affiliated with the Paris-Saclay University, INSERM, and APHP and CEA. I'd like to declare no conflict of interest regarding this study. So rituximab impacts COVID-19 infection in autoimmune disease patients with an increased risk ratio of death, as has been nicely demonstrated recently, around 4.4 in a study by Stranchfeld and collaborators. Something also interesting to mention is that the antibody response to the vaccine is diminished in autoimmune disease patients, with a response rate around 30 to 40%, depending on the studies, which is clearly diminished compared to other treatments. Other subjects around the vaccine response are still controversial, with some studies showing a diminished T cell response in rituximab treated patients, and others preserved T cell response. And these appearingly conflicting results might be due to different ways to detect the T cell response, either interferon gamma release assay or interferon gamma ELISpot. So we decided to do a prospective study comparing the antibody response, the neutralizing antibody response, and the CD4 and CD8 T cell response to mRNA COVID-19 vaccine between autoimmune disease patient treated with rituximab, autoimmune disease patient treated with other immunosuppressants or immunomodulatory agents, or healthy controls. The methods we used, this was an observational case control monocentric study between January and May 2021. Patients were autoimmune disease patients in our center in Le Kremlin-Bicêtre in France. And we defined the rituximab group with a last infusion in the previous year. And this was part of usual care. Patient received 2 injections of BNT 16-2B2 at day 0 and day 28, according to the guidelines. The endpoint was at 1 month post second injection. We measured anti-spike and anti-nucleocapsid ELISA. We did a surrogate neutralization assay, and we used flow cytometric intracellular staining for 3 different cytokines, interferon gamma, TNF, and IL-2 on activated CD154 and CD4 T cells and CD137 positive CD8 T cells. We compared stimulation with control medium or spike peptides, and used the method of intracellular staining to detect the cytokines in those cell subsets. The demographics and baseline characteristics were as follows. We had matched controls and age and sex compared to the rituximab group and the other therapy group. Other immunosuppressant group patients were around 60 years of age. Most of the patients were rheumatoid arthritis patients, and the second largest population was Sjogren's syndrome, reflecting the patient we take care of in our department. Patient had steroids, around 20% in the rituximab group and 40% in the other immunosuppressant group, with doses which were similar and below 5 milligram per day of prednisone. Also, a lot of patients were on methotrexate, 42% in the rituximab group and 34% in the other IS group. Regarding the results, the humoral response, I also like to mention that the size of the groups were 27 patients in the control group, 24 patients in the rituximab group and 35 patients in the other therapy group. Regarding the humoral response, we compare the anti-spike response between those three groups, and we showed a significantly diminished response anti-spike. We also showed a significantly decreased response in the surrogate neutralization assay between rituximab and healthy controls, and between rituximab and other immunosuppressants. Just as in the anti-spike response, we saw a very nice correlation between neutralizing antibodies and the anti-spike response, with an R around 0.86, showing that there was a good correlation. And we decided to establish a threshold of anti-spike response, which corresponded to 97% of participants with detectable neutralizing antibody. And this is how we defined the percentage of responders. It's not only the detection of anti-spike, but the detection of anti-spike with a neutralizing ability. And so the percentage of responders were 92% in the healthy control group, 29% in the rituximab group, and 80% in the other immunosuppressant group, with significantly diminished in the rituximab group compared to healthy control and other immunosuppressants, respectively. The factors implicated in the humoral response were the time since last infusion, with a significantly higher time since last infusion in the antibody responders compared to the antibody non-responders. And something that is very interesting, I think, for clinician, is that no patient with infusion in the last 6 months presented a response, as we defined previously, with anti-spike that have a neutralizing ability. Regarding the T-cell response, we were able to show that the mRNA COVID-19 generated spike-specific cytokine response of T-cells was significantly more important when cells were stimulated with the spike peptides compared to the non-stimulated condition. This was true for all three cytokines, for interferon gamma, TNF, and IL-2. And for all three groups, healthy controls, rituximab, and other immunosuppressants. For the CD4, for the CD8 response, there was less conditions where it was detected, but most conditions showed a significant difference between non-stimulated and the peptide-stimulated conditions. The functional cytokine response in activated CD4 and CD8 T cells, which is the main results regarding the T cell response, we showed that there was no difference between the healthy control, rituximab, and other immunosuppressant groups in both CD4 and CD8 T cells, and also for all three cytokines, interferon gamma, TNF, and IL-2. So this overall shows that there's no elements in our hands and with the technique we used to see that rituximab reduce the T-cell response to mRNA COVID vaccine. We also were interested in comparing the T-cell response between antibody responders and non-responders in the rituximab group. And we're able to show that there was no difference in CD4 T cells in all three cytokines. And interestingly, we're able to show that in the CD8 T cell, whereas for interferon gamma and IL-2, it was similar to CD4 T cells. There was no difference between antibody responders and antibody non-responders in the rituximab group. There was a trend towards a higher CD8 T cell response against TNF alpha in the antibody non-responder group compared to the antibody responders, as if having no antibody would impact the T cell response and have a positive impact on the CD8 T cell response in this group. So in order to discuss these results, and especially regarding this effect in the CD8 population, even though in our study it wasn't significant, we looked at the literature, and there's a macaque study showing that the CD8 depletion in the condition with low antibody convalescent animals leads to a higher replication after re-challenge with COVID-19 vaccine. So this gives a flavor of what correlate of protection these CD8s might have, and how important they might be to fight against the infection in a condition where antibodies are not present or are present at low concentrations. But this, of course, is only a hint and needs to be confirmed in a clinical study in patients. And also in another study published in Nature Medicine in September 2021, in multiple sclerosis patients who are also treated with anti-CD20, not only rituximab, but other molecules also. The authors confirmed the results regarding the similar T-cell response in the control group and in the antibody responders and non-responders patients. But they saw a higher, and this time a significantly higher CD8 T-cell response in antibody non-responders compared to controls, which is also something interesting to mention in our context. So in conclusion, autoimmune disease patient treated with rituximab, vaccinated with a BNT162b2 mRNA COVID-19 vaccine show an impaired humoral response if rituximab is given in the last 6 months specifically, but they show a preserved T-cell response. This might be an incentive to vaccinate at any time to build at least a T-cell response, and we can always boost and at a later time point to build a humoral response when the effect of rituximab has waned. Larger studies are needed to assess the potential of protection granted by a T-cell response without antibody to prevent COVID-19 disease. I'd like to once again thank all my co-authors in this author, the clinicians, the virologists who performed the anti-spike and surrogate neutralization assays, those immunologists who perform the analysis of the T-cell response, and my PI, Professor Xavier Mariette, who initiated this project and guided me through doing it, and also the nurses and the other doctors who took care of the vaccination program in our department, which was very helpful for the patients to do, and which was very successful. Thank you again for this opportunity to share our work, and I hope this enlightens the debate on vaccination in the specific population in autoimmune disease patients treated with rituximab.
Hi, I'm Robert Spira from Hospital for Special Surgery and Weill Cornell Medical College, and I'm going to talk about our abstract. B-cell reconstitution is strongly associated with COVID-19 vaccine responsiveness in rheumatic disease patients treated with rituximab. By way of background, we know that a challenge for clinicians as we've approached the pandemic is trying to understand how our diseases and how the medications used to treat our diseases might affect responsiveness to COVID vaccines, especially as those became available earlier this year. In some prior work that our group had done, we demonstrated that of approximately 90 patients on various anti-rheumatic medications, patients with rituximab seem to be much more likely to not demonstrate a serologic response to the vaccine than patients treated with other immunomodulatory therapies. We know that rituximab has previously been shown to impair antibody response to other vaccines, such as influenza vaccine and streptococcus vaccine. And guidelines are being developed, and they continue to evolve, how to approach rituximab use and timing of vaccination in the context of the pandemic with regard to the COVID-19 vaccinations. In this analysis, we looked at a cohort of patients who were treated with rituximab and had received a full series of vaccination, and did a retrospective analysis of their vaccine response as measured by antibody levels. So again, the methods were that this was a retrospective chart review, and we included patients who had been treated with rituximab at any point in the past and had completed their series of vaccination against COVID-19. We collected demographic information, their diagnoses, concurrent therapies, vaccine types and dates, and importantly, we collected the time from last rituximab infusion to vaccination, as well as a quantitative serologic vaccine response. What was different about this analysis than some others, though, is we also hypothesized that CD19 positivity, meaning the beginnings of reconstitution of detectable peripheral B cells, would likely predict vaccine responsiveness. This is something we had recognized in our initial series of patients looked at as potentially being a predictive factor, and we thought we would test that specifically in this retrospective analysis. And we used descriptive statistics and bivariate comparisons were performed, and we also calculated negative and positive predicted values between COVID-19 serologic response and B cell reconstitution status. So we identified 58 patients who met criteria for inclusion. The majority were female and Caucasian, and the mean age was about 63 years. And we had information about B cell reconstitution in about 71% of patients. What we found was that time from last rituximab was significantly longer in seropositive patients compared to seronegative patients, which is something that others have observed as well. We also found there was a significant difference in B cell reconstitution between patients who had positive antibody responses to those who had negative antibody responses. And in terms of thinking of these patients in buckets, most guidelines have used time from last rituximab infusion to help inform likelihood of a vaccine response, at least in terms of how that could be captured by serologic response. And what we found is that in patients more than 12 months since their last rituximab infusion, only 12% did not demonstrate a serologic response. Whereas if we looked at patients who were less than 6 months from the time of the last rituximab exposure, about 86% of patients did not demonstrate a serologic response. So a very substantial proportion of patients, the vast majority of those less than 6 months, did not have a serologic response to the vaccine. If we look at the patients between 6 and 12 months from last rituximab exposure, as many as 50% did not demonstrate a serologic response to the vaccine. But then if we incorporated B cell reconstitution into that analysis, we found that if you look at patients who had detectable B cells, 92% of those patients who were greater than 6 months from their last rituximab exposure, who were B cell reconstituting at the time of measurement of antibodies, did have a positive response, whereas only 76% of patients who were greater than 6 months from last rituximab exposure, without knowing their B cell reconstitution status, had a serologic response to the vaccine. Similarly, if we look at patients from 6 to 12 months from last rituximab exposure, where only 50% were seropositive, if you look at the group who were B cell reconstituted at the time this was measured, 83% responded among those with detectable B cells in that 6 to 12 month group. And finally, we calculated the positive predictive value of B cell reconstitution for the COVID serologic response to be 92%, and the negative predictive value was 68%, close to 69%. So in summary, this was a retrospective analysis with all the caveats that that entails. But we recognized that longer time from last rituximab infusion was associated with a greater likelihood of a serologic response to the vaccine. But B cell reconstitution also seemed to be associated with a much greater likelihood of demonstrating a serologic response to the COVID vaccine. And importantly, a really substantial number of patients who were greater than 6 months out from their last rituximab infusion did not demonstrate a serologic response. If we incorporated B-cell reconstitution, however, you could identify, we think, a group of patients who were much more likely to have a serologic response to the vaccine. And this could be important to strategies for maximizing responsiveness to the COVID vaccine, particularly in places where vaccine access is limited. So this needs to be looked at in further prospective experiences. Some of those studies are ongoing, but this gives us a hint that this really fairly readily accessible assay may help clinicians inform decisions about timing of administration of COVID vaccinations. And we think that perhaps this may also help inform decisions regarding timing of booster vaccines, as that has now become more relevant in rituximab-treated patients. Thank you very much.
Thanks for joining us for this edition of our ACR Authors Reviews. I hope you enjoyed these presentations. Make sure to subscribe to CSF podcasts on Apple, SoundCloud, or wherever you get your podcasts, so you don't miss out on our great Congress content or any of our other usual monthly podcasts. You can also visit the CSF webpage at cytokinesignaling.com, where you can access a whole range of resources, from monthly slide summaries of the latest papers to accredited CME courses and even more content in between. Thanks for listening, and come back often.